Hello, everyone, and welcome to today's OBSSR Director's webinar entitled The Theoretical and Practical Importance of Advancing Health Equity. I'm Jane Simoni, Director of the Office of Behavioral and Social Sciences Research at the National Institutes of Health. Before I introduce today's speaker, a few housekeeping items to mention. First, today's webinar is being recorded, and the recording will be available in about a month on the OBSSR website at obssr.od.nih.gov. Today's presentation will be followed by a Q&A session. All attendees are muted during the webinar, and the chat feature is disabled. However, questions and comments will be taken via the Zoom Q&A feature. To ask a question or send a comment, click on Q&A at the bottom of your Zoom screen, type in your question, and send. You have the option to like other questions to avoid duplicate posts. The most liked questions will move to the top. Feel free to send a question at any time during the webinar. Following the presentation, OBSSR's Dr. Bill Elwood will facilitate the Q&A session and ask your questions to the presenter. I'm pleased to introduce today's presenter, Dr. Neil Lewis, Jr. Neil is a behavioral and intervention scientist at Cornell University and Weill Cornell Medicine, where he is an associate professor in the Department of Communication, Division of General Internal Medicine, and graduate field of psychology. He also co-directs Cornell's Action Research Collaborative, which brings together researchers, practitioners, community members, and policymakers to address pressing issues in society. Dr. Lewis's research examines how people's social context and identities influence how they interpret and make meaning of the world around them, their motivation to pursue their goals and success in goal pursuit efforts, and the implication of these processes for interventions and policies to promote equity in social outcomes. Dr. Lewis has received the Early Career Scholar Award from the International Communication Association, the Janet Taylor Spence Award for transformative early career contributions from the Association for Psychological Science, the Cornell Research and Extension Award for outstanding accomplishments in science and public policy, and the Sage Young Scholar Early Career Award from the Society for Personality and Social Psychology. It's my pleasure then to welcome Dr. Neil Lewis, Jr. to present today on the theoretical and practical importance of advancing health equity.
Thank you so much for that really kind introduction, Jane, and good afternoon, everyone. Thanks to Bill, Erica, Jane, and everyone else at OBSSR and NIH for the invitation to speak in this webinar series. I'm really honored to have this opportunity to address this audience. What I want to do with my time today is talk about some of the bigger picture implications of a phrase that has become quite popular over the past few years, the phrase health equity. I want to talk about health equity and what it means to advance it, because I think doing so matters greatly for the kind of research that we do in the behavioral and social sciences research, and because it matters for the kinds of theories that we come up with and how we use those theories to create interventions and policies that have very serious implications for people's lives. Now, over the past few years, a lot of researchers have become interested in this topic of health equity. That interest, of course, not emerge out of thin air. It was prompted by a few major events. Most obviously, the coronavirus pandemic that emerged and started killing thousands of people, thousands and eventually millions of people. That really captured our collective attention around the world, as well as attention within the social and behavioral sciences about what we might potentially do about this issue. But another thing that became really clear very quickly as information about COVID started coming out is that the deaths from COVID were not evenly distributed, right? So here in the to focus just on the United States for a moment, from very early on, data started showing that Americans of color were dying at substantially higher rates than their white counterparts. So much so that by June of 2020, disparities were so stark that some estimates suggested that 1/3 of Black Americans by that point had already known someone personally who had died from COVID-19. Right, so these disparities in COVID were one of the things that got researchers really interested in this topic of health equity. And the other thing, of course, was another set of major social events in society: the killings of Breonna Taylor, killing of George Floyd, and others that also ended up prompting this national and global movement for racial and social justice. Now, because of these events happening at the same time, it really sparked this wave of new interest in the topic of health equity, even from people who hadn't really studied health equity before, or frankly, even seemed to notice many of these problems before. And this pattern became so pronounced that researchers who were sort of studying this movement within the field started to notice this pattern, ended up giving it a name. So and colleagues ended up calling this phenomena of sort of the wave of new interest, health equity tourism. This paper is really interesting and one that I recommend that viewers read. By health equity tourism, what these authors meant is that there are a number of people who previously didn't pay much attention to health equity issues, didn't do much research in the area, but suddenly swooped in like tourists and took an interest and then jumped in with proposed solutions to these problems, even if they didn't fully understand the broader context and body of literature that was built over the years on this topic. Now, I want to be clear. People becoming interested in health equity and wanting to work on this topic is not a bad thing inherently, right? I think the field, I think the social and behavioral sciences and the world over would be better off if more researchers paid attention to these issues more often. And I'll explain why I think that in the rest of the talk. But the problem is that just swooping in with solutions without knowing the history and knowing the broader context can do more harm than good if we're not careful. For a variety of reasons that some of my collaborators and I outlined in another paper that we ended up writing back in 2020. It can be really difficult to improve health in general, and certainly to advance health equity in particular, if we don't do the careful work that's necessary to understand and learn how these longstanding issues emerged in the first place, and then therefore what we can do when we build our knowledge base. So what I want to do with the rest of my time today is talk about how we can do better, right? How can we generate the theoretical foundations that are necessary to understand why we observe so many inequities in health outcomes in the United States and elsewhere, and how can we use those insights to prevent other catastrophes in the future, as well as respond to emerging issues that we are almost certain at this point will arise. Now, the first step for this is easy, right? That step is to actually stand on the shoulders of giants who came before us, who highlighted some of the fundamental social structures that are important to pay attention to if we want to understand and advance health equity. The issues that we're talking about in this domain are not actually new in some respects, right? And that fact is important to acknowledge as we go about this work. For about as long as data has been collected on this topic, scientists have found stark disparities in health outcomes in the United States. So we've known for a long time that people's health outcomes have long depended on their socioeconomic status, things like their race and ethnicity, their geography, where are they literally positioned within the country. We know that life expectancy outcomes, for instance, varies by where you live. And there are a number of other social markers that have well been documented. So you see these patterns over and over again in large national data sets, but you can also see them in smaller microcosms if you spend time working with more localized data sets. That's one of the contexts in which I first started paying attention to these issues. So I first started paying close attention to these patterns when I was a graduate student at the University of Michigan and living in Washtenaw County, Michigan. Now, back then in 2016, while I was still living there, I saw this presentation that really captured my attention and focused my interest in this area. And it's a presentation from a public health official who was sharing some data on health outcomes in our county. And that official pointed out that at the time, there's a 19-year gap in life expectancy between one end of our county and the other end of our county. So between the highest and lowest life expectancies in different municipalities. And the ordering of this life expectancy in these cities reflects the broader demographic patterns I was just talking about on the previous slide. Now, I'm not picking on the state of Michigan. What we saw in that context is not really that special. Michigan's not special in this regard. These days, I do a lot of my work in the state of New York and as well as in New York City. And the patterns are basically the same here. Because I do a lot of work in New York City, I pay close attention to New York City Health Department data. And this is one of the maps that they put together that captured my attention in that context. So this map shows you what the death rate for COVID has been like in that city, where darker areas on the map indicate places where death rate was higher, lighter areas indicate places where death rate were lower. What you see when you look at this map is that people in Midtown Manhattan, the wealthier and whiter parts of the city, did fairly well during the pandemic. But if you go north to the Bronx, you go east to Queens, you go south to Staten Island, where there are more lower income people and more people of color, things looked a bit different there, right? So much higher death rates in those contexts. So seeing patterns like this throughout my career has led me to ask you two broad questions in my work in trying to understand all of this. First, what mechanisms help to explain this pattern, like what is going on? And second, if we don't want to just continuously discuss sort of depressing statistics, what can we learn to try and do something to change them? One thing that I've learned over the years is that we really can't answer those questions without wrestling with the larger realities of the context that we all live in. We are living in what political scientist Jamila Mishner calls a fragmented democracy, right? We're living in a society in which there are deeply unequal social systems that structure the opportunities that people have to live healthy lives. We live in a nation, in a world with a long history of discriminatory policies and practices that have enduring structural and psychological effects in the present. If you're not as familiar with this history, I highly recommend this book by the historian Richard Rothstein, who sort of walked through the history of these laws in the United States. Now, Americans like to think these are problems of the past. So there's been some really fascinating research by Michael Krauss and Jennifer Richardson and their colleagues on this topic, showing that when you ask Americans about these issues, there's some acknowledgement that, yeah, we had these problems in the past, but we're sort of past this now, is sort of the thinking. But the reality is that we still see many effects of those policies today, and that matters for how we think about and understand health equity. And let me show you what I mean by that. So one of the concrete ways of seeing how this stuff matters is you can do things like take US Census data and use it to map where Americans live today. And the wonderful folks at the University of Virginia Cooper Center for Demography have done this. And what you see when you look at these maps is patterns like this all across the United States. So this map is of southeastern Michigan. Again, I first started paying attention to these patterns while I was there as a PhD student. And what you see in southeastern Michigan, think of this as the Detroit metro area, is that there's still high levels of racial and economic segregation today. So southeastern quadrant city, you have predominantly Black neighborhoods. You cross over eventually as you move north into white suburbs. You move out west, you see the same kinds of things. And you see patterns like this all over. Michigan is, again, not special in this regard. You see versions of this all over the United States. We just finished doing some cancer disparities research in Baltimore, Maryland. We see patterns like this there again. The configuration is slightly different in that context, but the broader pattern of segregation and separation replicates. We also just wrapped up some other work in the Philadelphia area. And again, same patterns of segregation there, different configurations, but same broader patterns of segregation. So my broader point here is that these are not problems of the past. They are problems that we still live with, problems that have enduring effects on our contemporary experiences in life. And I raise all of this to illustrate an important point for us to remember as we do this work, right? So the World Health Organization defines health as a state of complete mental, physical, and social well-being, not merely the absence of disease. Well, given the differences in life experiences that occur in these separate and unequal places, the opportunities to achieve that state of well-being are not evenly distributed, right? And we have to remember that as we go about this work, as we develop our theories and practices that stem from them. So when we live in unequal contexts like the ones that I've been talking about, we end up having really big issues that affect people's health. So why is that? Like, why do people's positions in society matter for their health? Well, of course, we can think about some of the obvious access-related issues. So where you live affects your access to quality healthcare. It's also associated with things like whether or not you have access to quality insurance, right? So if you don't have access to quality insurance, you don't have access to quality health facilities, that's going to affect how often you see health providers, the experiences you have with them, and so on. So that's one thing that obviously matters. But access isn't the only thing that's affected in these contexts. And we get a sense of that from some other data that show that disparities persist even in places with national health insurance. And even when you account for access issues by doing things like controlling for insurance status, you still see some of these disparities, with those at the bottom having worse health outcomes than those at the top. So access matters, but it's not everything. One of the other interesting things that happens in such an unequal society is that because people are in these segregated clusters, that starts to affect the way that they see, think about, and engage in health behaviors, right? They can start seeing health behaviors through the lens of important identity and group memberships that they see sort of clustered in those larger contexts in which they're embedded, right? So the context they're embedded in have scripts and narratives that go along with them, and that ends up affecting how people see, think about, and become concerned about different kinds of health behaviors. And those are some of the things that we've been studying over the years. In other words, in addition to having sort of direct effects on resources and affecting the resource kinds of explanations, patterns of inequality have another set of effects too. They have these intervening effects that can end up seeping into the mind and affect the way that people think. We've learned that they affect whether people end up thinking about health and health behaviors in ways that are connected to important social identities, whether they end up feeling like particular health behaviors are things people like them should do, and ends up affecting how people interpret their experiences along the way. So achieving good health often comes with some difficulties, right? And so one of the things we've learned is how people end up thinking about those difficulties is also a function of how they are embedded in these contexts. So we have to understand those patterns in order to know how to develop sort of more precise theories, as well as how to develop interventions to change behaviors. And I'll share a few examples to illustrate what I mean by this, because I realize that was somewhat abstract. So I'll start off by sharing a pandemic example of how these kinds of processes played out. So you might remember that at the beginning of the pandemic, before we had high quality masks readily available, public health officials were making announcements that people should wear homemade masks to sort of stop the spread of the virus. You might remember these as the days when people were walking around with bandanas covering their face, right? Well, when health officials made those announcements, it created some dilemma for some groups of Americans. And one that this was created a particularly strong dilemma for was Black men in the US. And the reason for this is that Black men are often harassed and killed in the US for appearing threatening. And so there's often a need to be vigilant about how you appear in public, because if someone sees you, they feel threatened by your appearance, they might call the police, and that could be the end of your life, right? And that's something you constantly have to think about as a Black person living in this country, right? So when health officials were making these recommendations, it invoked different kinds of risk calculations for some groups, right? Which risks do you want to take, like COVID or the police, right? That's the kind of relative risk judgment that some of us had to make. I'm sure there are some in the audience that think what I just said sounds like paranoia and like a ridiculous thing to be concerned about. But some researchers at UNC actually ran some studies to test how wearing different kinds of face coverings affect the perceptions of different groups of people, and their findings suggest that these concerns were not unreasonable to have. Specifically, in their studies, they found that Black men are perceived to be more threatening and less trustworthy when wearing homemade face masks than when they were wearing surgical masks. Participants didn't really care what white people wore. So what kinds of masks did not affect judgments, but it did matter what kinds of face coverings Black men were wearing. And so that's the kind of thing that you have to think about, how these broader social contexts can affect how individuals within the society have to think and navigate health decisions. And so, yeah, I'm just bringing this up to illustrate again how these broader cultural and social contexts and inequality that exists within the larger society can shape how people have to think about and sometimes have to worry about even seemingly innocuous health behaviors like should I wear a face covering? We, as researchers and health policy making bodies, have to remember and think about those things when studying health behaviors and designing interventions and policies to change them. And this is not just a pandemic thing, right? These processes are related to many other health behaviors as well. And I'll share some examples from some of the other work that we've been doing over the years, exploring these dynamics. So before COVID came along, I was studying the other pandemic that really shaped modern public health, and that is HIV and the disparities in those outcomes. So about a decade ago, we were really alarmed by some statistics about HIV that were coming out of the CDC at the time, and that really prompted some of the work that I'm going to share now. So here's what alarmed us. When you look at population sort of representation, what you see is that Black Americans make up about 13% of the US population. But at the time when we started doing this work, they were accounting for 54% of new HIV deaths and 44% of new diagnoses. So this was 2013, 2015 data, pretty stark disparities, especially for that time. You know, those numbers are really alarming in their own right, but they're alarming because if you talk to people in public health and look at where efforts have been, Black Americans have often been prime targets for HIV prevention messages and other kinds of interventions. So since social scientists have spent so much time designing messages that's supposed to be resonant with Black audiences, we really shouldn't be seeing patterns like this at this point in time. But one of the things that happens, though, that we've sort of learned over the years from the process is that despite all the efforts to design those messages, when you take those messages outside of the context of the laboratory, you deploy them in real world settings, researchers have found over and over again that Black audiences have been reluctant to pay attention to them in the context of public settings. So that's something that we became really interested in, is this question of like, why ignore this potentially life-saving information? Well, to answer that question, you have to go back to dynamics that unfold in the social structures that I've been talking about, right? So when you look at the literature on the history of the HIV and AIDS pandemic in the US, one of the things you'll see is that HIV got deeply racialized and moralized in ways that made it particularly stigmatizing for Black communities, right? So there is general stigma around HIV, but that stigma is particularly strong in Black communities due to the history of how that pandemic unfolded. And political scientist Kathy Cohen wrote a really great book on that topic if you'd like to learn more about that history. Well, because of this strong stigma, though, it started to make sense why people would be concerned about this, right? Why you might not want to pay attention to this information, especially if others around you, right? Paying attention could be threatening to your self-image and your reputation. And it could signal to others around you that maybe you engage in behaviors that are stigmatized by in-group peers, right? It's one thing to look at the information in the context of a university laboratory when no one else is around. It's another thing to look at this information in public spaces where other people, particularly other people whose opinions you might care about, might see you, right? It could communicate to others, again, that you've engaged in these behaviors that they might disapprove of. But the implications of that history, though, is that it might lead people to avoid useful health information, right? But if that is the case, then the kinds of messages that we actually roll out in public health interventions might have some issues. They might not do what we designed them to do. So we decided to test this idea by actually partnering with a health clinic to conduct a field experiment to see what is the effect of these messages in context. And so we worked with the clinic to manipulate what kind of health information was being displayed in their waiting room and observed how much attention patients paid to the information. So in one context, we had HIV prevention information playing on the waiting room monitors. And then sort of in the control condition, we had a flu prevention message playing on the waiting room monitors, and then we could study what the effects of attention were. And so we were able to sort of train research assistants so that the messages are sort of being displayed. This is a schematic of what the clinic looked like. Messages are being displayed on the monitors, and research assistants were positioned so that they could see how much attention people are actually paying attention to these messages. And so the way that we did this, because again, it's in this field setting, we were capturing this overt measure of attention using a previously established coding scheme. So participants got an aggregate score in this context. So they are, get a score on this scale where they had to get a 0 if they're completely ignoring the information. These videos are about 20 minutes long on a loop, and if you never look at it, you're getting a 0. And you get a 1 if you're sometimes paying attention to it. And if you get a 2 if you're like paying lots of attention to the information there, you're really focused in on watching these messages. And so this is a coding scheme that was previously established by Dolores Halvorsen and other colleagues. So what we were able to do then is we have we manipulated the message. We could see whether people are paying attention to it, and we could look at this attention as a function of both what is being played as well as who else is around at the time to really see what's going on here. And what we found was really interesting. So for white patients in the clinic, well, for them, what we found was not that interesting. We didn't find very much. They didn't pay much attention to the message. It didn't matter what message was on display. It didn't matter whether it was a flu message or an HIV message. And it didn't really matter who else was around at the time. They weren't really paying much attention to what was going on. But for Black patients, the patterns were much more interesting. It really depended on what was being displayed and who else was around at the time. So when the HIV message was being played in the clinic, if you were the only Black patient around, you're willing to pay a moderate amount of attention to it. But as the concentration of Black patients in the clinic increased, Black patients actually paid less attention to the HIV message, right? So if others are around, potentially seeing you watch this, then your likelihood of paying attention goes down. And this pattern is sort of consistent with the idea that maybe you're concerned about these kinds of judgments that might affect your attention. And we can be somewhat confident about that because we didn't see that with the flu information. Flu actually went in the opposite direction. That was not predicted. We expected just a flat line with flu, but it is interesting that this HIV pattern in particular is showing this this relationship where it seems that people may be concerned about what other members of the in-group might think that might affect attention patterns. Let's see. But for me, findings like this really highlight the importance of going out into the world and studying the health behaviors in the very context in which they occur, right? If we're serious about wanting to improve our theories of health behaviors and about developing the kinds of interventions that can advance health equity, then as social and behavioral scientists, we have to do more than just studies of undergrads in the laboratory or MTurk workers online. Like those studies certainly have their place in our knowledge production toolkit, but we also need to do more of the kinds of studies that allow us to capture and measure variation in context so that we can incorporate that into our theorizing, right? That will allow us to generate theories that are better specified. And I think will give us greater insights into the conditions under which it's helpful or unhelpful to apply particular research insights into various problems that come up in the world. The HIV study isn't the only place where we learned a lot from paying attention to what was going on in broader society outside the lab. There is a version of this during COVID, and I can show you what I mean by that. So during the first year of the pandemic, my collaborators and I were able to study COVID-19 concerns among over 31,000 Americans using survey methodology in that context. So in this study, we got to look at survey responses about COVID concerns on sort of a monthly basis from March 2020 to March 2021, and really see whether and how those concerns might have changed over time to help us understand what else might be going on, some of the other patterns that we've observed in society. So yeah, that's, as I just mentioned, allows us to look at levels of concern, how it varied by time, as well as other things like people's racial and ethnic group memberships, given the patterns that I've been talking about so far. What we found there was significant racial and ethnic group differences that started early in the pandemic and persisted across time. So to sort of pull out some highlights from this, what we saw is Black and Hispanic Americans had the highest levels of concern about COVID outbreaks, and that sort of persisted across that first year of the pandemic. And these concerns make sense given some of the data I started talking about at the beginning, right? The data suggesting that the deaths were really concentrated in certain communities, so it makes sense that members of those communities would be particularly concerned. But what's interesting, another thing that's interesting from seeing those differences in concerns is that it can help us to make sense of some of the broader discourse that was unfolding about COVID mitigation policies. This is another thing that was like always in the back of my mind as we did this work, is just how were people thinking about these COVID policies to address a variety of issues that we're talking about in society. And this showed up in some interesting ways in other public opinion data as well as other kinds of methods. So my former colleagues at 538 ended up writing a piece back in June 2020 showing public opinion data about changes in how Americans thought about how the government should respond to the pandemic by prioritizing public health versus the economy in particular. This was the big debate at that time. And in March of 2020, what public opinion data was showing was that Americans of all backgrounds were pretty united, right, in the agreement that the government should take all necessary steps to ensure that the public is safe, even if that meant keeping some businesses closed and potentially hurting the economy. So lots of agreement around that. But by June, though, once word was out that it was mostly Black and Brown folks who were dying, Black and Hispanic Americans were still committed to prioritizing public health above all else. But white Americans actually became less convinced that that was necessary, right? So what was going on in society was really changing how people were thinking about this issue. And this showed up not just in public opinion data over time. Experimental data found this as well. So Alison Skinner and her colleagues, her team published a paper last year that really talked about this kind of finding. They experimentally exposed white Americans to information about COVID-19 racial disparities. And what they found is that seeing that information, that again, that it's mostly people of color dying, actually lowered white Americans' fear of COVID, reduced their empathy for those who are vulnerable to COVID-19, and reduced their support for COVID safety policies, COVID mitigation policies. So again, this is another place where it seems that people's contexts, their identities are affecting the way that they process information about a health threat, right? If they get information that suggests that their group is not at risk or is at lower risk of experiencing consequential outcomes, then they don't seem to care as much anymore, right? They're willing to, in some ways, sacrifice other groups to go back to normal. And this is why I think we have to pay so much attention to like what information people are getting in their information environments about these things, right? And how that information is framed. The content can really matter a lot for people's understanding of what's going on, as well as what they want to do with that understanding. And so findings like that are why lately I've become more and more interested in the ways that our broader public and social institutions end up communicating about these issues, health equity issues, and social issues more broadly, right? How do we talk about these issues and what to do about them? Because these ways, different ways of communicating, seem to have some interesting effects on the way that people think, feel, and behave. So these days, I'm part of a group known as the Collaborative on Media and Messaging for Health and Social Policy. I know it's a mouthful, but this group is a tri-institutional collaborative between Cornell University, the University of Minnesota, and Wesleyan University. And what we do in this collaborative is we really study how public discourse around health and other equity issues really affect attitudes and support for health issues and social policies. One of the ways that we do this is by actually studying what happens on the airwaves across the United States, right? So in the US, there are 210 different television markets. This is sort of how the media divides up the ecosystem in the US. And in each of those markets, there are 3 to 4 local news broadcasts that happen every day, right? So there's an early morning broadcast, there's a lunchtime broadcast, there's a dinner time broadcast, and some places also do a late night news broadcast. And this is still where most Americans are getting a lot of their news, news about health, right? So one of the things our team is able to do is then take these broadcasts that are happening all the time and have both human coders as well as computer software actually watch and code samples of those broadcasts to learn what Americans are actually seeing in their news about health issues. And that enables us to learn more about why they might think about health issues in the ways that they do. One of the things we've been curious about over the past couple of years, given the data that I just showed you, was how were these COVID disparities being covered in the news, right? And what might that mean for Americans' understanding of the pandemic? So find out, our team coded and content analyzed news coverage of disparities during the first wave of the pandemic. And for this project, again, we really wanted to know how news stories that were talking about disparities were covering these issues, right? So we're interested in news coverage in general, but in part because of a parallel conversation that was happening among experts in health institutions. So in the public health world, an interesting thing was happening during the pandemic, right? Health departments and other public health officials were seeing this data about disparate hospitalizations and deaths in COVID, and were saying that this was due to racism in our society that affects people's vulnerabilities to the coronavirus disease, right? So many health officials went as far as declaring racism as a public health crisis that needs to be addressed in the United States. So there were, 231 such declarations in the US. And so this is what the health officials were saying. There's a question of, well, how far is that going? Are media organizations also saying that? Since, the media is where people are looking for their health information, they're not necessarily paying attention to the intricacies of what public health officials say. And so we looked to see what the media said. And we found that the media didn't quite go there, right? So they did talk about the fact that Black and brown people were dying at disproportionate rates, but in our analysis, we found that only 9% of those news stories talked about the role of racism in that, right? And there was this question that came up as we were doing this work. Well, did that change after George Floyd was killed? There was so much sort of discussions about racism after that. Did that potentially change the way that discourse happened? And no, we didn't find any difference from before to after George Floyd's murder. And that null finding is sort of consistent with a lot of work that's been coming out lately about, the racial reckoning that really wasn't in some ways. Now, why should we care about these issues and how they're covered? Well, there's a large body of research in communication and public health that's found that how the media frames discourse shapes the way that people think about the causes, the consequences, and solutions for public health issues and other social problems, right? When you talk about the fact that there are health disparities, but not why those disparities came to be, Americans end up making individual essentializing essential attributions for them, right? There must be something wrong with those people, why they keep dying, right? And if that's your explanation for why some groups are dying more than the other, then the natural conclusion of that is there's really nothing that the government needs to do, right? That's their problem, it's those people's problems, not a collective problem that we all need to address with interventions and policies, right? And so these kinds of ways of thinking make it really difficult for us to come together and develop collective and effective solutions that might be necessary to address the pressing problems that we face, right? Especially when these equity issues are put on the table. So that's why we've been paying so much attention to these kind of discourse. We've seen that play out throughout the entire COVID pandemic, how difficult it's been to rally people to address these larger existential threats that we faced over the past few years. But it's not just COVID that makes me sort of concerned about this, right? I have to admit that I'm a bit worried about how these dynamics will play out in the context of what is arguably an even larger collective action problem that we'll be dealing with in the years to come, right? The environmental crisis that we're facing, which also, of course, has huge health inequality implications. We're going to have to figure this stuff out because these are issues that we'll continue to deal with in the many years and decades to come. This will be difficult work. I'm not going to sugarcoat that. I think sugarcoating things is part of how we ended up in some of this mess in the first place, right? That's a topic of a whole other talk that I don't have time for today. But what I want to sort of note is that just because it is difficult, that doesn't mean that we should give up on this, right? So for me, the difficulty in these issues is a signal of the importance of us, behavioral and social sciences researchers, taking the time to go on the journey of engaging more deeply with the various external forces that are affecting what's going on inside people's heads, right? It highlights the importance of taking the time to study the structural, the cultural, and political forces that shape the nature and operation of our society, and by extension, the people in it. You know, if we're going out more and studying the power of the situation, if you will, then I think we'll have a better understanding of how our various minds work as we wrestle with these issues. And I think we'll be better equipped to turn our knowledge into action to address these problems that occupy so much of our time and attention. For me, that's one of the legacies of our field that I'm really proud of, that I think we can reclaim to take action and improve outcomes and equity in the modern world. And that's what I hope that we spend more and more time doing in the years to come. But doing this work, though, requires strong teams and it requires a tremendous amount of support. The work itself is a collective enterprise. So in closing, I just want to thank some of the remarkable team of students, collaborators, community partners, policymakers who've contributed to the work I've shared today, and who've really, more than that, been shaping the way that I think about these issues over the years. And I also, of course, want to thank the funders who have all generously supported these research efforts. So thank you again for inviting me to give this talk, and for all of you who have attended, and I'd be happy to answer questions there. Thanks again.
Thanks so much, Dr. Lewis. Before we get to some questions, I think I'd like to, I think it's appropriate to quote Dr. Srivastava, who had a question, but I think first we could lead with, thank you, Dr. Lewis, for the interesting presentation. And there's lots of claps, and you can see the emojis floating through the screen. I'll start with her question. It's interesting that white people tend to withdraw some support for COVID mitigation policies upon finding out how it primarily affects Black people. Do you think it has to do with the nature of human selfishness rather than race specifically? For example, do you think the same results would have been found if white Americans found out that COVID primarily affects Canadians? For example, not them, but removing the race aspect.
Yeah, that's a really interesting question. You know, our data can speak to that directly, but I think there's a broader body of work that we might be able to draw on here. Like, I do think some of this is fundamental, like in-group, out-group dynamics. And you know, if it's not affecting your group, it can be harder to care as much. One of the lines of work that I find really interesting in this is which groups do you consider to be part of your sort of moral circles? This is Larissa Heifetz's work on the more we sort of expand our moral circles to include other groups, then we become more concerned about their concerns. Like if it's affecting them, it's affecting me. And there's also work on from political science on linked fate that talks about that kind of idea as well. The other area, though, that I think gives us some insights about this is the work on social trust. And I've been looking a lot of this with the environmental side, right? That in societies where there's sort of more social trust amongst people, there does seem to be more of this sort of collective care, right? And I think this is sort of a broader societal thing that we have to wrestle with in the US. Like because we are such an individualistic society, there is less of that sort of collective focus. And I think that's part of what's going on here. I do think the history of racism is a big part of it too, but there are also some other mechanisms here that I think doing some work.
Terrific. Would you, I have another, it's a bit of a complex question, but it starts with something I got to share. Yeah. This is a wonderful, logically sound, and scientifically backed presentation. My question surrounds the idea of how to push/motivate behavioral social science researchers to understand that anti-racism, anti-bias work is inherently a health intervention. How do you feel that our academic system can motivate anti-racist approaches to health? And given your opening point about health equity tourism, how can we sustain the movement in a Lewis and, I might say, Lewin, continuing the tradition kind of way?
Yeah, so I love this question, and especially in this context of this being an NIH webinar, because I do think people respond to incentives. One of the reasons for the big wave of interest in health equity during the pandemic, I think, is because a lot of money went there, right? There were rapid response grants from NIH, there were rapid response grants from NSF, there were rapid response grants from everywhere. And so suddenly, there was this interest. Well, there's money to do this now. And so lots of people wanted to get on board, whereas before the money was so much about, well, just do the basic science, and the application stuff is second tier. So I do think what we fund is as an enterprise is a signal of what we value. And so the funding is one piece of it. And the other part of it is how we think about this with our journals and departments and university promotion criteria as well, right? So I've written some other papers about this, about like what counts as good science. This is a long-standing debate within the social behavioral sciences, with sort of the basic quote unquote basic work being seen as better than the applied work. And we have to work on that too. But I think we really have to wrestle with these larger incentive structures in order for this to be sustained. Otherwise, when NIH dumps a ton of money, people will do it. And when the money goes away, they'll go back to their the other things that they can get money to do. So
thank you for keeping it real and intellectual. We had quite a number of questions that came up, and had a number of upvotes on, it's an oversimplification, but to say demographics. Mm-hmm. For example, have you seen, when you were talking about the census maps, have you seen similar or different interactions with race, gender, age, generations?
So we look a lot at race and gender, race, ethnicity, and gender. Age hasn't come up as much in a lot of our findings, but we've been thinking much more about those nuances and the intersections between these things, right? So, in the presentation, I know I sort of talked more categorically, but thinking about the intersections between these categories is super important. Another one that we're paying more and more attention to is sexuality, right? And how the stigmas play out there that affect many of these other outcomes. And MPOX was one of those contexts where we saw, again, the interactions between sexuality and race and gender playing out for both infection rates as well as who got vaccines and who did not, those things being kind of different. So I think it's really important to continue to dig deep as we do this work moving forward.
Excellent. Thank you. It sounds like you are bringing all of those variables together to do research in a Crenshawian intersexual kind of way.
I think it's really important, right? Because that's as people. So if we take a step back and think about what is our job as social and behavioral sciences, we're really trying to understand people's experiences in the world, right? And how that might play out for these various outcomes that we care about. Well, people are not walking around with just one of those things, right? They are walking around as whole people who are experiencing these dynamics in very interactive ways. And so I do think we have to think about that. We historically have not, I think, dealt with research in that way methodologically for some of the background incentive reasons that we've talked about, right? To do that kind of work really well, you need to be able to recruit the right samples, and sometimes, and depending on the nature of your design, enough people to be able to say something. And so and that has implications for how long it takes to do a study, how long it takes to publish a study, the timelines of promotion. Is there grant funding for that? So I'm always trying to be mindful of the work that needs to be done in the context in which we as researchers are also doing that work, and really dealing with that.
Perfect. I have some more questions to get to, but Jane, I see you on screen. I wonder if you had a question or a comment at this time.
No, it's just, a lot of things we could talk about, but I wanted to give people in the audience a chance to ask anything.
Oh, okay. I don't know that we can unmute them, but I do have a few.
No, but I'll read the questions.
ahead.
I was going to say read the questions. Yeah.
Okay. I guess this is a bit related to the intersection. Neil, are there any particular health behavior models or frameworks that you think are useful to develop effective communication? This questioner recognizes that communication is important, but has to be complemented with access and other interventions.
Yeah, this is it's a really big and interesting question. I spent a year on an NIH advisory group on this very question of it was a group on health behavior theories and which ones should we use. So there are lots of them. I'm not gonna. There are lots of them out there. And when you talk about effective communication, we really have to think about what that means. And for me, I sort of think about first what behaviors are we trying to change, and then sort of work backwards a little bit to see what theories are there. I personally, again, operate a lot from the identity-based motivation framework, in part because that's what I sort of was trained up with and know how to think about how it relates to how it bridges the context with the individual level factors, and I'm sort of back and forth there. But I can't give a general answer, in part because I first want to know what behaviors are you trying to change, and I might draw on a different set of theories, for instance, for communication campaigns around HIV than when I'm doing work on vaccine uptake, and so on. Yeah.
Terrific. We have so many more questions that I wish we could get to. Rather than a question, I'd like to point out a compliment from our NIH colleague, Dr. Melissa Green Parker, who says, "Thank you so much for raising this awareness about the health of caregivers and family members of Black men, because that is such an impactful issue. The constant stress about worrying about their safety and well-being at any given moment is just a chronic stressor that doesn't get the attention that it deserves.
Yeah, thank you for those comments. And I'll note like that moment too, in time, like I had that tension. Like I'm like, when I saw the news too about wearing these face coverings and bandanas, I'm like, on one hand, I'm a Cornell professor, right, who is at a medical school as well, right, doing research on health and health behavior change interventions. And I'm like, I get it. I get why you're making these recommendations. And on the other hand, I'm a Black man in America who was walking around, right, and knows what the potential risks are. And so I'm like, there was this tension for me as I was living through that moment, thinking about how do I like go out and navigate this world, as I'm like, when I'm, at that time we we're just in the house doing research. I'm like, in the house I can like do it all here, but like when I leave the house, like I have to think about these things, right? And so it is not just an abstract idea, and I think that's another part, sort of larger meta point of the talk is these are not abstract ideas and abstract issues. They are things that are affecting people's lives every day, and we have to remember that. I think to make sure we're being careful as we're doing the work, because it really matters for people's lives.
Perfectly put. Thank you. And a great note on which to thank you again for sharing your research and bringing and your full self in this presentation. Let me turn it over to Dr. Simone to thank you officially on behalf of the entire agency.
Thank you, Dr. Elwood. And thank you, Neil, for a wonderful talk. We really appreciate it. This presentation on the theoretical and practical importance of advancing health equity was excellent. Thank you all also, the panelists, Erica Moore here at OBSSR, who was our comms director. Thank you all who joined online today, almost 500 people. If you have colleagues who are unable to join and may be interested, remind them the recording of today's webinar will be available in approximately 1 month on the OBSSR website at obssr.od.nih.gov. And please mark your calendars for the annual NIH Behavioral and Social Sciences Research Festival to be held on Tuesday, December 5th. The agenda and registration information will be available soon. And please subscribe to OBSSR's listserv to receive updates on upcoming events, again at obssr.od.nih.gov. This concludes today's webinar. Thank you for attending and have a great day.
Thank you.